So I'll talk about D-dimer since D-dimer is one of the tests that frequently order in Ibn Nafis. Maybe Dr. Shamil, maybe he receive a lot of referral from us because of this. So what is D-dimer is given for a families of fibrin fragments which circulate in the bloodstream after thrombotic or activation of coagulation cascade. It had been introduced in 1970 to check the presence of DIC initially, and it was not identified as separate molecules. Mainly they call it, fibrin degradation product. Then they separate them in small and big molecules. So it is one of the cornerstone tests in several conditions, especially acute medicine. And thanks to Sarah, she gave me the statistics in Ibn Nafis. See, we have done almost, maybe by today, maybe we completed 300. So if not completed, because today one of my patients definitely will have. So I request some of the doctors to complete it, so we have a good figure, 300 at least. If you see, positive is 83, which is, I know the interpretation will be difficult, but it is 83. And the good thing that it's going with the low-risk patients. So most of them is outpatients. So it's utility mainly in low-risk patients for thromboembolism, not in patients like hospitalized for surgeries or for acute illness. So which is good, reflecting a good practice. So it is, we know the complex of coagulation cascade in our body. So the activation of thrombin converts soluble fibrinogen to fibrin through cleavage of fibrinopeptides from N-terminal domain. And this fibrin will polymer with together, and factor 10 will be activated. And with thrombin, which activate the cross-linking of D domain of adjacent fibrin molecules, stabilizing the clots. When the clots stabilize, then the plasminogen will get activated, and this leads to degradation of cross-linked fibrin molecules. And degradation will produce this one, the FDB, which is fibrin degradation product, and the dimer generation. Yeah, I mean, see, I'll show you, see, like this. See, you have, this is the fibrinogen, and the thrombin will be act on it. And when the clots made, cross-linked, then done by activated factor 10, which is very essential for the clot formation. When this cross-linked form, then the other part of the tissue that make the dissolution of the clots is the plasminogen.
Which factor is it?
Plasminogen, plasmin. And plasminogen activated to plasmin, and this degrade the cross-linked fibrinogen to FDB, which is fibrinogen degradation product, and a smaller molecule, which is a D-dimer. So
the fibrins and the level of the fibrins in the blood to prevent the incidence of blood clot, I mean embolism?
No, this is routine, normal physiology in our any injury that you make in our body, this cascade get activated.
Okay, so the blood will stop, bleeding will stop.
It will stop bleeding, yes. After bleeding stop, and then when homeostasis is achieved, then the plasminogen will try to degrade the clot formation and make this one cross-linked circulate in your body, so you know there is some injury. Like, for that reason, if you have any surgery, there will be a damage of blood vessels. And these blood vessels require homeostasis to be activated. And the activation through thrombin, the activate factor 10, this will cleave the fibrinogen to fibrins, and cross-link done with the presence, of course, of factor 13 also to stabilize the clot. And then the plasminogen will cause the degradation of fibrin, cross-linked only fibrin will produce FDB and D-dimer.
Let me just, because we know it's far away from our understanding. a patient comes for us with subconjunctival hemorrhage.
Yeah.
And there's really clot, there, blood clot, subconjunctival. You can see it not leaking outside, covered by the conjunctiva, not leaking inside the eye because there is a sclera there.
Yeah.
And we don't do nothing. It will clear.
Yeah.
It depends how dense it will clear after 10 days. or
Yes.
something.
Yeah.
Now you are explaining for us what is happening because
Yes.
what is going on.
Yes. This is what happened. The clots form, homeostasis achieved, sealed, then the plasminogen will degrade this clots and normalize the endothelium. Yeah.
So the white blood corpuscles, the scavengers will come and eat the...
It's part of it. It is very complex. This is just simply we haven't talked about platelets. It's not only one factor. This is only part of it is coagulation factors, which is protein mainly. But of course, there will be platelets aggregation. There will be activation of WBCs. There's so many involved in factors and the coagulation. It's not only just. This is part of it only. It's very, as we said initially. See, it is a very complex process involving several molecules and different pathways. So it's not. This is just to explain why we depend on D-dimer, because it's considered like a biomarker that could be utilized for us in acute setting, in acute medicine. Well, otherwise, it's not just only we have platelets, we have calcium, we have RBCs, we have WBC, all involved in coagulation.
So patients on anticoagulants will have different...
It will target one of these pathways. So we have, for example, antiplatelets, which will target the platelets. And we have the heparin, for example, it will be antithrombin. And we or thrombin inhibitors, the new DAWAC and so on. So we have so many anticoagulation that target different pathways of coagulation cascade. So we end up with FDB and D-dimer degeneration. So the D-dimer generation require activity of 3 enzymes: thrombin, activated factor 10, which is factor 10A, and plasmin. These are needed to generate D-dimer. It functions as indirect marker of thrombotic and subsequent thrombolytic activity. And it may result the D-dimer result may not be comparable among various assays because of employment of monoclonal antibodies with varying specificities for D-dimer. Probably the companies that going to sponsor this meeting, thank for them. They will explain more about this. And from time of its formation, D-dimer began to be detectable. This is some of the kinetics about D-dimer in 2 hours, and half-life approximately for 6 hours. After surgery, the D-dimer increase and peaking about in 1 week, and then decrease by 5 to 10% daily. So it is detectable for at least 1 month if there's no ongoing of course, coagulation or injury or endothelial injury. This is from the net. So you have this clot, and this is the FDB, the bigger molecules, and we have the D-dimer, smaller molecules. Of course, there's a lot of fibrinogen equivalent units or the D-dimer units. That's the maybe technical, probably explained by the companies. Talk about this. Okay, so there are numerous commercial D-dimer assays, a whole blood agglutination test, semi-quantitative assays, ELISA, LFA, and latex agglutination test. And this epipeptide absent in non-crossed, only in crossed, as we said, fibrin monomer. D-dimer tend to increase in several clinical conditions, and its use in emergency department can be affected by low diagnostic specificity. If you go to there's one investigator analyzed 1,600 cases accessing the emergency department to rule out venous thromboembolism, regardless the pretest probability. and they showed that D-dimer level increased mainly in infection, which is most frequent diagnosis, thromboembolism 12.1, and syncope 9.4, and heart failure 8.9, and trauma 8.2. So, and cancer. Of course, in all these conditions, the D-dimer could increase. For that reason, the specificity, especially in patients with acute illness, is low. So it's better to be used in other conditions.
Why it is increasing? Why is it increasing?
Because in this condition, because there will be activation of coagulation factors. Any endothelial injury by surgery, by trauma, by disease will cause D-dimer to increase. So its utility for diagnosis in this condition is not good. We'll come to that in the. So, and D-dimer elevated in older individuals, even in the absence of detectable thrombosis. And the hypothesis behind this that the aging is pro-inflammatory state, which normally seen in elderly patients. And diagnostic specificity is even lost to even less than 10% in people with when they reach their 80s. So for that reason, it is advisable to have reported the age-adjusted cutoff to improve diagnostic accuracy to detect thromboembolism in elderly. And some validated studies put the factor of 10 nanogram per ml when you report the D-dimer for age. For example, if the cutoff, for example, 500, if somebody came with possibility of BE and you want to report it, you multiply it by 10. So, for example, 70, you report it as 700, age-adjusted D-dimer. So in elderly, you have to be careful when you interpret the D-dimer level. It's also part of it is clear by kidneys. So in the kidneys also, maybe D-dimer utility has a problem. Especially, they are also at high risk of thromboembolism. This investigation has conducted studies on almost 10,000 people, and he identified a cutoff of D-dimer and different glomerular filtration rate. So almost like 500 when the GFR 30 to 60, above 60, and 1,300 with GFR 30 to 60. So maybe you consider this normal in patient with this GFR 30 to 60. If even less than 30, it reached up to 1,600 nanogram per liter. So you have to be careful with when you interpret D-dimer in patient with renal failure also, because partly it's excreted by the kidney. In pregnancy also, we know the pregnancy is hypercoagulable state, so D-dimer will be found. So you have to also, when a patient is pregnant, because of placenta formation, because of stagnation in lower part of the body by gravid uterus, this all will cause activation of coagulation. For that reason, one of the studies identified a cutoff of 1,500, considered normal in pregnancy. And when it is more than 1,900, in presence of false criteria or prior probability for BE, considered to be positive.
So it is a protective mechanism in the body to minimize the chances of intravascular hematoma.
Bleeding, yes, part of the defense mechanism for a human. But when there is injury, it is a marker of something going on in the body. It's like it's acute phase reaction that it happens when there's endothelial injury. There will be activation of coagulation. So we utilize this as a biomarker when somebody presents with an illness. If the D-dimer normal, that means we are okay. That means there is nothing, or there's no much of injury. But when it is high, outside the clinical context of surgery, trauma, then you think there might be something. So it's good a biomarker to detect injuries or thromboembolism, or even sometimes viral infection. We'll come to that in the subsequent slides. So its utilization mainly as a biomarker for thromboembolism. So this is for pregnancy. So maybe 2,000 with the presence of Wills criteria. Always we use it with, when you diagnose BE, it has to be with prior probability. And this is just a cause of D-dimer elevation. Thromboembolism is the one which we are using it, the IC, and also age, even cigarette smoking. Cigarette smoking is associated with endothelial injury. So it also can increase the, but there's no data about its normal level or cutoff value in cigarette smoking. So how we use it? We use it, somebody come with dyspnea or shortness of breath, chest pain, syncope. This is the main utilization of D-dimer in acute medicine. Of course, as we said, in low risk group. So D-dimer has a pivotal role in diagnostic pathway of pulmonary embolism. And when they present with dyspnea or syncope, these are one of these main complaint or main presentation of patient with BE, and it is useful to suspect pulmonary embolism, DVT, and aortic syndrome. Even in aortic dissection, it is also elevated because it's also endothelial injury. So this is very important. When patient is hemodynamically unstable and there is high suspicion of BE, you don't do the D-dimer. Because it is high or low, doesn't mean anything. You go directly to CT angio. This is only, as we said, when the patient is low risk group. So in real clinical practice, over-testing is very frequent. So a prospective observational study, including 3,000 people visiting accident emergency, 25% they did for them CT or VQ scan, even in the absence of predisposing factor or presentation of or suspicion of pulmonary embolism. So we expose them to CT scan, radiology, and risk of contrast unnecessarily. So we have to be practical, a combination of symptoms and clinical finding with the presence of predisposing factor for pulmonary or for venous thromboembolism, classify the patient on high risk group, low risk group, or intermediate group. And most of them, 40% with BE, they have no predisposing factor found in accident emergency. And sometimes we just discover them for vague symptoms, and we discover that maybe our colleagues in 24 hours, we have found cases like this, like that case, maybe Dr. Shamil, remember, a patient who has sickle cell disease. She had undergone uterine surgery for prolapse, and she came after, maybe, you remember her, Dr. Sharif, patient, and she came after 2 weeks with flank pain and chest pain, pleurotic chest pain, and what we did was only just D-dimer, which was very high, 1,600. We did CT angio, it was positive for BE, and she has risk factor. So this is appropriate patient that to consider D-dimer in it, because it's not during acute illness. And so it is one of the strategies to reduce exposing this patient to CT angio is by doing for very cheap and quick test, which is a D-dimer test. So the diagnosis of venous thromboembolism is strongly supported by D-dimer measurement. Is currently considered the biochemical gold standard in diagnostic assessment of patient with suspected venous thromboembolism. And this is the Wills criteria or Geneva scores or Wills scores. So when a patient come and you stratify them according to the possibility of BE. So you have Wills criteria or Geneva criteria. When low risk group less than 2, moderate 2 to 6, and above 7 considered to be high risk. So these are the patients who require to be done for them CT angio. But patient with low risk group, here you can go easily with just D-dimer. So a score of low or unlikely to be have thromboembolism, D-dimer level is negative, then khalas, you don't need to do CT angio. For a patient, if of course D-dimer result positive, you go for imaging study. Patient with moderate to high risk group, you don't need to do the D-dimer because anyway you are going to do more confirmatory tests, which is a CT angio or VQ scan. So this is the cascade, or this is the pathway. So when you have somebody who has high risk group, Wells criteria or Geneva criteria, a low risk group, D-dimer. If it is less than 500 nanogram per ml, or which is low, be excluded. If it is even low risk group and the D-dimer is high, you go for imaging studies, CTBA or VQ scan. Moderate and high risk, directly you go directly to CTBA, and no need for D-dimer. So another utility of D-dimer is the chest pain. So BE can present also with chest pain, and MI also can present with chest pain, and D-dimer troponin increase in both conditions, aortic dissection also. So utility of D-dimer troponin ratio is useful tools to discriminate between two conditions of BE and non-STEMI acute MI. Because in the presence of STEMI or high ST segment elevation MI, you don't need to do D-dimer, it is BE. But when there is non-STEMI, the D-dimer to troponin ratio more than 1.8, you consider CTBA before referral the patient to cardiology or for CT angio or for coronary angio. So this is a good tools to calculate, which is when both of them positive and the ratio more than 1.8 of D-dimer to troponin, consider CTBA before coronary angio. D-dimer also here, Dr. Hasan, it's used also as a prognostic value. We know it is increase in acute illness. So Rodillo studied 28 days mortality and several biomarkers and sepsis, including D-dimers, C-reactive protein, procalcitonin, SOFA score, and Apache scores. D-dimer was found to be only biomarker that exhibit strong linear relationship with 28 days mortality. So the more D-dimer in sepsis, the likelihood of a bad outcome. Same thing in COVID. 343 patient classified or high risk, or the people with D-dimer more than 2,000 have higher mortality with sensitivity of 92%. So elevation also in D-dimer and COVID patient also has therapeutic implication. That mean we have to intensify the prophylaxis therapy because they are at high risk of thromboembolism. So in conclusion, the D-dimer represents a useful, cheap test easily available in most of emergency departments. Knowing which patient will benefit from determination of D-dimer level and selecting them appropriately can help an emergency physician or help the emergency physician to avoid unnecessarily imaging tests. The employment of D-dimer as prognosticator need to be confirmed in large studies, as well as it's used to guide the treatment. Like, for example, when it comes down with, for example, initiation of antibiotic or treatment of acute illness, it may be evolving in near future, but need more studies. Thank you, and Happy New Year.